Thank you for this opportunity to present our research. We have no relevant financial disclosures. Pelvic organ prolapse is a common medical condition with up to 19% lifetime risk of requiring surgery. Up to 17% of hysterectomies are performed for prolapse indications nationally. In 2017, American College of Obstetricians and Gynecologists published a practice bulletin stating that hysterectomy alone is not an adequate treatment for prolapse, and they recommended performing concurrent apical suspension procedure. Prior to these guidelines, a national database study found that only 51.8% of hysterectomies done for prolapse had a concurrent apical suspension procedure performed. Our primary objective was to compare national surgical practice patterns of performing apical suspension procedure at the time of hysterectomy for prolapse before and after the 2017 ACOG Practice Bulletin publication. This was a retrospective cohort analysis of the National Surgical Quality Improvement Program database for the years 2015 through 2016 and 2018 through 2019. Cases were included based on CPT codes for benign hysterectomy and diagnostic codes for pelvic organ prolapse. Exclusion criteria are as listed. The cohorts were defined based on the year of surgery before and after the 2017 ACOG Practice Bulletin publication. The primary outcome was the proportion of hysterectomy cases performed with an apical suspension procedure. For the purpose of this study, enteroceal repair CPT codes were not considered to constitute an apical suspension procedure, but are reported. Secondary outcomes include proportion of apical suspension procedures performed by urogynecologists compared to general gynecologists, as well as performance of minor prolapse procedures. A total of 11,742 cases were included in this study. Women in the 2018 to 2019 cohort were slightly older, were less likely to smoke, with differences reported in race. There was no difference in BMI or parity between the groups. General gynecologists performed more cases than urogynecologists, with narrowing of the gap by the 2018 to 2019 cohort. Minority of the cases were performed by other subspecialties. The primary prolapse diagnosis in majority of the cases was apical prolapse, with no difference between the two groups. There was a slight increase in minor complications, but no difference in major complications between the two cohorts. When looking at a primary outcome, the overall rate of concurrent apical repair procedure increased slightly after the 2017 ACOG Practice Bulletin publication, from 49.4% to 51.3%. A CPT code for enteroceal repair was used in minority of the cases, with fewer cases in 2018 to 2019 cohort. Use of both anterior and posterior repairs increased in 2018 to 2019. When stratifying our primary outcome by surgical training, we saw that urogynecologists performed apical suspension procedures in almost twice the number of cases compared to general gynecologists. The overall use of CPT codes for enteroceal repairs did not differ between the two groups. When assessing the impact of the 2017 ACOG Practice Bulletin by surgical training, we saw that urogynecologists had a slight but statistically significant increase in the use of apical suspension procedures, while the same was not noted for the general gynecologist group. The use of CPT codes for enteroceal repair decreased for urogynecologists and increased for general gynecologists. Regression analysis was used to look for predictors of performing a hysterectomy without an apical suspension procedure. This showed that general gynecologists were more than twice as likely to omit an apical suspension procedure compared to urogynecologists. Compared to white race, several other races were also at a higher risk of undergoing hysterectomy without an apical suspension procedure. On the other hand, longer operative time was associated with a lower risk of undergoing a hysterectomy without an apical suspension procedure. In conclusion, we saw only a slight increase in utilization of apical suspension procedures done at the time of hysterectomy for prolapse after the publication of the 2017 ACOG Practice Bulletin. Urogynecologists were more likely than general gynecologists to utilize an apical suspension procedure. This study highlights an area of opportunity for improvement in patient care with utilization of apical suspension procedures.